Hello and welcome to this training on evolving cancer therapies and the nursing role. Today, Laurie-Ann Holmes will present the highlights from 2024 Canadian Association of Nurses in Oncology Symposium on bispecific antibodies. My name is Brooke Dewhurst and I am the Community Services Lead for the Atlantic Provinces at the Leukemia and Lymphoma Society of Canada. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We listen attentively and with compassion to the challenges you and our community are facing, and we can point them to information specific to the blood cancer or treatment. We help them get organized to manage and take charge of their care, and we also identify services that would be beneficial for them. We offer a continuing education platform that you can join free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. They are all offered by experts. Close to 2,000 healthcare professionals are using the platform, and there are 80 trainings available on blood cancer, treatments, psychosocial aspects of cancer, and more. We are adding trainings regularly as well. Available online are all of our education tools and resources, vetted by experts for all the main types of blood cancer treatments, secondary effects, and more. Our material is available in multimedia formats to address the variety of needs and preferences. This includes digital disease booklets, fact sheets, podcast episodes, animated videos, and webcast recordings. All of these tools and more can be ordered or downloaded through our website. You can order our TeraPads for easy reference to our services or blood cancer literature to inform those affected and the families that you support. It's easy to do and free of charge. Most of our educational materials can also be downloaded from our website. Emotional and practical support is a main priority for the LLSC. Our peer support program, for example, has been identified as a key service, but many do not know about it. Trained volunteer survivors who are at least 1 year post-treatment share their stories with newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are considered to ensure the best possible match. This program helps to build hope, alleviate anxiety, and create realistic expectations. We also have professionally facilitated virtual support groups. These support groups, offered coast to coast, gives the opportunity to the blood cancer community to connect with others who are facing same challenges in the comfort of their own home. Each participant builds connection through the group discussions, sharing coping methods and information, and to help with isolation. Please visit our website, www.bloodcancers.ca, to reach the community services lead in your region for more details. I'm now pleased to introduce our speaker today, Laurie-Ann Holmes. Laurie-Ann is a nurse educator at the Ottawa Hospital. Majority of her career has focused on oncology, with the last 10 years specializing in malignant hematology. She is an active member of CANO, nationally on the Education Committee, and co-chairs on the Hematology Special Interest Group. Over to you, Laurie-Ann.
Thank you very much for that welcome. I'm happy to be here to share some of our learnings. First of all, I just want to acknowledge the land that we are on, the unceded land and territory. I am in Ottawa, which is part of the Algonquin Anishinaabe, and it's important for us to always recognize and honor the land that we are on here in Canada. So when Pascal had asked me to talk about bispecifics, I did go down looking at some of the treatments we've had over the years for cancer therapy. And so the first one, of course, we know and we're quite familiar with chemotherapy, the use of chemicals to treat cancer. Came in the early 1930s. They started to see, we saw nitrogen mustard had benefit with lymphoma. And then we've gone on to many other different things in the 50s using vincas, plant alkaloids to treat leukemia. And so we've come a long way with a lot of different things, in 1958, combination therapy to treat and cure ALL. Then all of a sudden explosion, targeted therapy, drugs to target specific molecules on or inside cancer cells. This led to personalized cancer treatment based on the biology of the individual's cancer. So for us in hematology, the key thing was the discovery of the Philadelphia chromosome, which led to the development of imatinib or Gleevec, which was a big thing for us in cancer care. And then, of course, our monoclonal antibodies that developed. Rituximab was one of the first monoclonal antibodies targeting CD20 being used to treat lymphoma. Changing gears, we started looking at immune therapy. But actually, immune therapy was discovered a long time ago. In 1891 was the first record of discussion about immune therapy. But in 1996, we saw the development of these blocking molecules and that either take the brakes off or ramp up your immune system. So now we're looking at harnessing your immune system to treat and fight a cancer. So great strides have come with that in our therapies. And what came further with that was the development of our CAR T therapy, chimeric antigen T cell therapy, where here genetically modified T cells are designed to recognize specific antigens on tumor cells, resulting in their activation and proliferation, eventually resulting in significant and durable destruction of malignant cells. In Canada, they were approved in 2018. They still are only available at select centers, usually a transplant center. Part of the requirement, usually these centers had to go through specific cellular therapy accreditation. They're not, we thought at first it was the holy grail for cancer therapy. It is not 100% effective, so less than 50% of patients will be cured with this treatment. And it does require toxicity observation and management. So as you can see in the picture, the patient's T cells are removed by apheresis. They're sent to a pharmaceutical lab where they're injected with a viral vector. They grow and replicate and reach a certain number. They'll be taken off, cryopreserved, sent back to the center. We give the patients a little bit of chemotherapy, lymphodepleting to bring down that response, and infuse them back. They grow, replicate, and ramp up your immune system to target your disease. Now we have bispecific T cell engagers designed to simultaneously bind to tumor cells and T cells to elicit a tumor-directed immune response. So I was fortunate, I think my next slide talks about being at CANO. One of my colleagues, Cheryl Page, presented about these bispecifics. So what happens here is they recruit and activate of immune cells or T cell engagers. One side binds to an antigen and the other binds to another cell like CD3, the effector on the T cell and natural killer cells that activate and allows targeted and kills tumor cells. They block signaling pathway, so growth of tumor cells can be stimulated and modulated by the receptors, tyrokinase, and will block that signaling pathway, can simultaneously reduce tumor cell escape and improve the therapeutic efficacy. They blocking of immune checkpoints, so monoclonal drugs targeting that immune, so can again have that synergistic effect generated by that combination, and forcing association of protein complexes binding to two specific molecules. So more bang for our buck. And she did discuss that, there was over 13 approved products, 180 in clinical trials, in preclinical, and 50 in clinical trials. So yes, this was from my colleague Cheryl Page, and I've been asked to talk about what I learned at CANO. And At CANO, I was very fortunate to attend in Newfoundland a gathering of over 500 oncology nurses. And one of the posters there by Jocelyn Hill from Vancouver had, bispecifics are coming, but no, they're here. They've hit us with a bing bang quick. So there was at the conference at least 9 industry and nurse-led presentations on bispecifics and a couple of posters. So what's the deal with bispecific? So the first thing, when we're looking at rolling out this new immune targeted therapy, we talk about preparing, and that was a lot of the presentations were on areas preparing. So because of the side effects, which I'll get into, one thing is centers have to be able to admit patients if needed. They have to have access to an intensive care. They have to be able to manage the inpatient volumes and have a clear pathway for admissions. We are looking at outpatient delivery, and some centers, I will share, have identified that and looked at what type of patient would benefit and would be able to tolerate. We have to have that flexibility that if the patient had issues with toxicities, that we could directly admit them. We have to have guidelines on how to manage these toxicities. And really important, of course, develop a plan for education for all healthcare providers in hospital and outside in our communities. So my colleagues at UHN presented that they have developed this inpatient, outpatient format for these bispecific treatments. So they had sort of 3 streams for that ramp up dosing that they do. And they base it on the patient's condition, the tolerance of the patient, and if they have a caregiver that can support them during the acute phase after their treatment. So they have an inpatient, a combination inpatient, outpatient, or an outpatient stream. And so they developed an eligibility checklist to help them identify which patient could fit into which category. They had strict guidelines on outpatient caregiver criteria, patient and caregiver education. They developed a patient monitoring tool. They provided staff education, and they developed an after-hours telephone triage line for their patients. At Grand River Hospital, they shared and talked to us about how to implement it in a community hospital. So they developed an emergency department alert, a rescue medication administration guide, rapid access to care, and outpatient workflow. So that was a great thing because we are going to see these treatments in our smaller community centers versus just the CAR-T in your transplant center. So what's all the big deal about bispecifics? Well, the big thing is one of the major toxicities we can see is cytokine release syndrome, and that's a systemic inflammatory response triggered by infections and certain drugs, like our immune therapy drugs and our bispecifics. So large amounts of lymphocytes and our myeloid cells are activated, leading to the rapid release of a large amount of inflammatory cytokines. The incidence can vary widely depending on the type of cancer therapy and diagnosis. So here, the symptoms, it basically can affect every organ in the body, usually beginning with a fever, but can range from mild flu-like symptoms, myalgia, headache, to conditions of vasodilatory shock capillary leak syndrome. So that is why it's important to develop guidelines and supports for your institution. So again, the hallmark signs of your cytokine reaction is fever, hypoxia, and hypotension. So we have taken now, with these treatments that are ramping up your immune system, we're basing everything that we're doing presently on guidelines that were developed for CAR-T therapy. So the American Society of Transplant and Cellular Therapy has developed guidelines and a grading system with regards to your cytokine reaction, looking at your fever, your hypotension and hypoxia. And from those guidelines, they've developed strategies. One of the key things that we can do with the bispecifics versus the CAR T is that they've already planned in some preventative strategies or mitigation strategies. And they look at most of them will have a ramp up dosing where we're gradually increasing the dose till we get to the ideal treatable dose. And that helps with mitigation of the severity of your reaction. The other things, patients all get pre-medication. And the incidence depends on the product, can range from 14% to 89%. It is slightly higher seen with IV formulation versus sub-Q formulation. So this is an example of a modified from the American guidelines, looking at your grading and what type of manage you would be doing, right? When you have a fever, we're going to first of all do an infectious workup, blood culture, starting them on antibiotics, and monitor them. But then if they get into anything like a grade 2, having hypotension, we're adding some fluid boluses, monitoring. If they're still going on, then we might bring in some other additional ways to treat and manage them. And again, at these points, then are you bringing them into inpatient areas for observation? So depends, again, after that grade 1 can be managed potentially as an outpatient if you have resources. PMH was setting up their patients with, SAT monitors and things like that. Can we all do that? I'm not sure, but that was part of their trial that they were looking at. But again, that caregiver support is important and that access. So there is a drug to help settle down that inflammatory response, and it's called tocilizumab. It's a humanized monoclonal antibody that blocks the binding of the IL-6 receptor. It's given over 60 minutes. Tolerated quite well. And in my CAR T population, we've seen resolution of fever, usually within 24, 48 hours, and normalization of the BP and the oxygen demands. Part of the requirement of centers administering bispecifics or CAR T is that they have a minimum of 2 doses available for the patient before we start treatment, just because of this cytokine reaction. Tocilizumab was initially is used also to treat rheumatoid arthritis. We did use it a bit during COVID, but it is quite effective. There are other agents that they could use if your patient's not responding to tocilizumab. With my personal experience with bispecifics, we rarely need to use the tocilizumab. So that is good. And when I talk about some of the different treatments, we'll see that. The other toxicity that we see is your immune effector cell-associated encephalopathy, or ICANS. And they're not 100% sure of what happens here. With most of these treatments, they prefer your patient doesn't have any CNS involvement, but they feel that the bispecifics are able to interact with the immune and tumor cells simultaneously, and thought to bring about endothelial cell activation, which disrupts that blood-brain barrier. So we can see that inflammation in the brain, and it can range, medium time to onset is 2 days, but can range from 118 days. It's quicker. We see ICANS quicker with bispecifics than CAR T. CAR T, it's usually 3 to 4 days. This can be in 2 days. And so what do we do as nurses? First of all, we're monitoring. We're doing at least every 8 hours or 12 hours, we're doing this ICE scoring, where we're looking at orientation of your patient. And then we're doing handwriting skills. So I always tell my nurses, if at any point there's hesitation in their answer, they can't tell me this is a cup, then they fail. If there's hesitation, my nurse the other day, I was quite happy. The patient was struggling. Her writing was beautiful, where they have to write the same sentence every time, and you're looking for those changes in their handwriting. But the patient really struggled to start and to get that handwriting. We've had scenarios where with bispecifics, I've, heard my nurse trying to do the ICE score. We do it before we start treatment to get a baseline. And then we will do it, as I said, every 8 to 12 hours, PRN, if there's any change that you notice in your patient. And she was trying hard to get the ice score baseline, and the patient only scored a 5 to start with. So that was what our baseline was, because that was what his mental capacity was to start. And that's what we would have to use to go forward. Again, the ASD has developed consensus guidelines. So they'll take that ICE score that the nurse has done, and we'll plot that, and we'll look at then other things, the level of consciousness, if they're having any seizures, any motor changes, or signs of an increased intracranial pressure. And that will give us our grading with regards to our ICANS. When we're looking at management of our ICANS, initially, it's all supportive when we're looking at those early stages. We have found that it's okay to give steroids. We're not going to diminish the activity of these engaged T cells by giving some steroids to suppress and bring down the action there. Some patients will be on anticonvulsants. They might start with CAR T, that's part of our protocol, but it isn't standard with our bispecifics. Neurology is important to be involved with your team, to be aware of what's going on at your center, what you're doing. Then again, as per the guidelines in the management using the AST guidelines, then we might be looking at a lumbar puncture, an EAG, MRI. As the patient progresses with each scoring, goes down in the scoring, then that's when we would also be transferring them to an ICU. I have not seen in my practice yet anybody having any severe ICANS with the bispecifics. I've had some patients, they say they're a bit foggy. One patient was having a little bit of hallucinations, but most have minimal ICANS compared to our CAR T population. The other thing that's one of the industry presentations talked about was infection. Again, these patients, this is third, fourth line treatment. They've got a blood disease, so they are more prone to infection with these treatments. So again, basic patient education, hand hygiene, avoid, temperature monitoring, avoiding people that are sick. We will have, most of our patients will be on prophylactic medications like acyclovir, Septra. They do also recommend, like our CAR T population, to monitor your IG levels. So when it's less than 4, we might have to see that some patients, we will need to support them with immunoglobulins to help them with regards to infection. So it's interesting, because as I said, it's big fuss, it's big lot of movement, everything going on about bispecifics. And actually, we have been using bispecifics for quite a bit of time. Blinatumomab was approved in 2014, and it was the first bispecific for our relapse refractory or MRD, minimal residual disease, ALL, that is CD19 positive. And it was rolled out, and I don't think we had a big fuss about this when it came out or knew as much about it. This one, the CRS can be about 11%. Most are mild. The first treatment, we start in hospital, usually for at least 9 days. For 7 days, they'll get 9 micrograms, and then we go up to 28 micrograms. It's a continuous infusion for 28 days. Neurotoxicity is seen about 5%. Infection is 43%. The patients will all get pre-medicated with Decadron, and if there's any stoppage in the infusion, we have to pre-medicate again. So this has been a great treatment for our patients in that relapse refractory or minimal residual disease. Sometimes we give 2 cycles and get them to transplant. People that aren't transplant eligible, we might continue on to have a total of 5 cycles. Epicortamab is one of the agents we heard about that's being used for your relapse refractory diffuse large B cell, mediastinal, a high-grade follicular also. For patients, it's given subcutaneously. And you can see the ramp up initially is quite slow. that you can see that gradual ramp up of this drug, 0.16 to then 48 milligrams. The incidence of CRS is about 50%. And again, we see the highest CRS after that day 15. So in some centers, they might be admitting your patient for the day 15 dose, because that's where we'll see about a 61% of CRS it talks about in that patient population, where, you know, the next time at day 22, when they get 48 milligrams, the CRS rate is only 6%. So by having a little exposure of that binding medication, they seem to do okay. Median onset to CRS is 2 days, usually resolves within 3 days, and only 28% of the patients required intervention with tocilizumab. Most commonly, it was fever, hypotension, hypoxia, chills, tachycardia, headache. For the ICANS, it was only seen in 6% of the patients, and majority, over 70% of that, were grade 1. And the onset was about, it was a little longer. It was about, it was at that 16.5, but that's when I've had my big dose at the 15 days to mark. And it usually lasted about 5 days. And in lots of patients, it's that fog that they talk about. And I realize I'm missing one slide. So there is another BiTE that we've been using called glofitamab. It is again for my relapse refractory diffuse large B-cell lymphoma. It is given by intravenous. And again, we do a gradual wrap up of dosing. It has a little higher CRS and neurotoxicity that we can see in the initial phases. But it is tolerated well overall. But again, we have to do that ramp up dosing with us. Teclistamab for our relapse refractory multiple myeloma. This one is also given subcutaneously. The CRS rate overall can be 72%, seeing majority are grade 1, 50% are grade 1, and usually after that initial first dose and then subsequently decrease. The median time is 2 days, and it's usually resolved within 2 days. They get treatment day 1, 4, and 7. We make sure that everything they resolve before subsequent dosing. Usually we see the common fever, hypoxia, chills, hypotension. Tocilizumab was used to treat it, the CRS in 35% in clinical trials. With neurological toxicity, overall, there was 15%, with headache being the most common, but your ICANS was only rated at 3%. And as I said, there has that step up dosing that then they would go to weekly dosing. Serious infection was seen in about 30% in trial, and IV immunoglobulin was administered for 53% for that hypogammaglobulinemia. Again, this has pre-medications with Decadron, Tylenol, Benadryl is what you will see with most of your agents. Elranatabamab is for your relapse refractory multiple myeloma. This one again is subcutaneously, and we ramp up every week, reaching then our target dose of 76 milligrams, and then they will change the frequency. The CRS rate overall is about, different sources were giving me different things, about 60%. Onset was about 2 days and usually resolved within 3 days. Again, we can see that with this drug, and we pre-medicate. The ICANS was low at about 3% in most cases of my resources, but again, we see aphasia, altered level of consciousness that we can see with this one. The last one is talaquimab for relapse refractory multiple myeloma. Again, this is given subcutaneously, Q weekly or Q2 week with a ramp up dosing. Overall, CRS was about 76%, but majority, 57% were grade 1. The ICANS we can see a range of 55%. Again, they're saying the majority of the symptoms when they were grouping it more as just neurological toxicity was headache. Um, you know, and then we might see some encephalopathy symptoms. Median onset was about 2.5 days and duration was about 2 days. Again, mostly confusional state, lethargy. So with all of our bispecifics, they do recommend that patients do not drive during that step-up dosing schedule and for 48 hours after the completion of the step-up dosing, or if they had, of course, any ongoing neurological toxicities. The other thing with this drug, they had some different other things. They had oral toxicity, so patients then had problems, dry mouth, dysphagia. We saw some weight loss. There's some skin toxicity, rashes, erythema reactions that you can see, and infection rate was about 16%. So the key thing was, as all of our centers prepare for the rollout of bispecifics, and many more are coming, is education, and then really ongoing education is important because as I said, the last one had some different side effects that we haven't seen. And we are seeing these agents now being used in solid tumor. There's a couple of agents for solid tumor for lung and melanoma, I believe, uveal cancer. So our med-onc population are referring to us for support and guidance as we've been used to dealing with this cytokine reaction and ICANS with our CAR-T population. So really important when your center's looking at the education, you're including your nurses, your physicians, your emergency department, your intensive cares, and also thinking about our community partners, your GPs, our home care resources, and that ongoing updates with them. There are a lot of resources and it's important, again, patients only retain 10% of what we tell them. So we need to make sure we provide them resources in a variety of formats, written, videos, handouts, and again, each time they come in, we reiterate and review the teaching with them. As we saw with PMH, they had set up that, that caregiver model, making sure they had a caregiver that would be monitoring them at home. My center with CAR-T, we do have the patients to have a little assessment that the caregiver would do regularly to make sure we're not getting into any problems with the cytokine reaction or the ICANS. I looked on the Great Leukemia Lymphoma Society, and they had some patient information sheets and an app for tracking your side effects. So lots of great things. The nice thing with our bispecifics is they're readily available. The CAR-T, we need to refer to a CAR-T center. They need to be approved. They need to then have that apheresis to take off the T cell. Then we have to wait for the development of those modified T cells, which can depend on the product, 3 to 4 weeks or longer with some of our newer ones that are coming for multiple myeloma. We're seeing that these bispecifics will be available in most centers. So our patients don't have to, and their families don't have to travel a great distance to access these treatments. There's gradual dosing, so potential to control for those adverse effects like our cytokine reaction and our ICANS with that gradual ramping up of our dosing and pre-medication. With CAR-T, we're giving that one big blast all at once. We can't turn off a switch that easily. So that's advantage. The disadvantage is that for some of these, we're looking at ongoing treatment until progression, until they're no longer responding. So versus CAR-T, where it's that one-time big bang that we've modified and got your immune system working against your cancer, and we might cure you. With this, we might have that ongoing. So it is one of the challenges that we can see. One of my, so bispecifics are targeted immune therapy showing treatment benefit for many hematological malignancies. Most are dosed in a step-up manner. Some are available sub-Q or intravenous. Most common side effects are your CRS and ICANS. So again, being prepared, it's important to educate yourself. It's important to educate your patients. And interestingly, we might see these branch out to other areas of our treatment. One of my colleagues, Margaret Forbes, a nurse practitioner actually in Hamilton, had some information about they might be effective for treating GVHD in the future. So lots of great things coming with these new treatments. But again, prepare yourself, educate, develop processes in your institution to manage these treatments, and have resources for your patients is important. I hope you will be able to join us at CANO's next conference in Banff, and encouraging everyone to become a CANO member. There's lots of resources there available, webinars, education, survival guides, and we have a special interest group. So I'm hoping you can join us. Thank you. And email me if you have any questions.
Thank you so much, Laurie-Ann, for this presentation. To you who are listening to us, I hope you all enjoyed it. We invite you to access the continuing education platform to view all the other training courses. I'd like to also note that this event was made possible thanks to the support of AbbVie. And finally, I would like to remind everyone that we are here for the blood cancer community. Do not hesitate to order our TeraPad for free or to contact us if you need any more information or support. I hope you have a wonderful rest of your day. Thank you.